everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Today, I'm delighted to have as our guest Dr. Amy Zhang. She's an associate clinical professor on the glaucoma service at the University of Michigan's Kellogg Eye Center. She was previously at Case Western University, where she was the glaucoma fellowship director. Her clinical interests are her work in minimally invasive glaucoma surgery and home tonometry. She is the well-being director for the Department of Ophthalmology and most recently a faculty associate of the Office of Well-being at Michigan Medicine. She has an interest in improving ophthalmic ergonomics as well as looking into addressing drivers of burnout across the health system. She has collaborated with the School of Kinesiology and has current collaborations with industrial engineering, examining the role of human factors engineering in healthcare. Hello, Amy, and a very, very warm welcome to the Surgical Ergonomics podcast.
Thank you so much for this invitation. I'm delighted to be here. It's always really encouraging to see others in the field who are so passionate about ergonomics. I think you and I can go on end nonstop to talk about this, but it's nice that there is a respective audience out there as well.
I agree 100%. This has really been a passion project. If I may, I'd like to start out by asking if you could just tell our listeners a little bit about yourself, including kind of your training background and how you landed up or arrived at your current role.
Sure, I would be delighted to do so. So I grew up in Michigan, and it had always been my goal to eventually return to my home state to practice. I had completed my medical school at the University of Pittsburgh, and following that, did my residency in ophthalmology at the University of Rochester. I did my glaucoma fellowship at Henry Ford in Detroit, Michigan, and then went away for a couple of years as faculty at Case Western Reserve, Cleveland, before coming back to Michigan and joining on as faculty. When I started at the university, one of the things I was directed to do was I had the opportunity to be a director at one of the satellites at the University of Michigan. And during that transition and during those roles, I quickly realized that there were a lot of inefficiencies in our health system. And I wanted to focus my efforts towards something that I thought all my colleagues were experiencing, which is burnout. And so I sort of shifted or pivoted towards the role of well-being. Concurrently, I've always had a passion for ergonomics. I'm on the shorter side, so for everything that's designed in this world, it never seems to be catered towards the shorter people. And I'm sure the same can be said for the taller folks as well. Especially in ophthalmology, there's actually a tremendous increase in musculoskeletal disorders compared to others in healthcare. So there has been a study done at the Mayo Clinic that sort of looked at musculoskeletal disorders in family practice practitioners versus ophthalmologists. And there was a sevenfold increase in terms of lower back pain and sort of just issues related to that. And I think part of it is just because we're so confined in both the clinic as well as the surgical setting. So for those of you who might have gone to see an ophthalmologist, we use that lamp. It's called the slit lamp, which is basically an upright microscope. That actually causes a lot of cervical neck issues as lower back pain as well. For me, it just was a passion project of mine to kind of see where are areas in which we can improve to sort of help build career longevity.
No, this is absolutely amazing and fascinating, all kind of rolled into one. we arrive at our interests in ergonomics in different ways. And as I, often say in my podcast, I'd like about the people as much as it is about what we need to do and the technology and the innovation, right? Thank you very much again for your interest in this area and for sharing your time with us today. When I give talks on ergonomics, I tell people, I said, there's no specialty that's immune to the effects of poor ergonomics. And you bring up an excellent point regarding sort of ophthalmologists because they're procedures in the OR, they're doing procedures in kind of an outpatient clinic setting. You have clinic procedures as well. And then, of course, you have your exam rooms where you're using the slit lamp facing issues related to that, the instrumentation. You also mentioned another thing. The value of ergonomics is highlighted if you happen to be at the extremes of any body anthropometrics, right? So if you're really short or really tall or really small or really tall, etc., those things seem to then aggravate these issues. We have a wide audience on the podcast. Let's say there are ophthalmologists. Can you help the residents who are training and the fellows, as well as the maybe people in practice who are starting to notice, MSK symptoms, as you said, neck and back and shoulders? What are some of the tips that you can share with them regarding setting up in the operating room and how they can help the nurses and other staff also set them up for ergonomic success?
Yeah, I think you bring up some really good points. I think education is definitely an area in which we really need to explore more. Certainly, as I was entering the field, it was not very much talked about. I remember one of the mentors when I mentioned, oh, this is kind of awkward. I'm not sure how much longer I can brace my arm up here while trying to visualize and see into the retina or the back of the eye. And the comment was, well, you'll figure it out. You'll just figure it out. And it's sort of like that figuring out process may not be so intuitive because I don't know how much ergonomics training you received as a medical student. I certainly did not. And so how would I know what would be the proper ergonomics? So I think initially it's so important for all of us to reach out to those around of us who are passionate about ergonomics or know a little bit and
Mm-hmm.
take that extra moment. One of the first things I do with our residents is number one, during orientation, I actually have a specific hour lecture that I give just to cover both the clinic and the OR side, but also any residents or fellows that operate with me, I tell them, before you start anything, I want you to be comfortable. And you're the primary surgeon. So, really, everything needs to be catered towards what's comfortable for you because it's already super stressful when you're operating. Can you imagine if you're uncomfortable and expected to do the procedure? That's just sort of insane. I think taking that extra moment, and it won't take very long if you actually time how long that adjustment takes, I think you'll pay dividends in the end. Imagine if you're not comfortable, you can barely, as an ophthalmologist, kind of use all four of your limbs because you have your two hands that are using inside the eye, and then there's a microscope foot pedal as well as another like either phaco emulsification foot pedal or for retina specialists, a vitrectomy foot pedal. So literally you're like using all four limbs at the same time. So if you can't reach one of your pedals or your pedals are just positioned super awkwardly, it's going to be really, really hard to operate and concentrate on the patient, which should
Mm-hmm.
be the primary person that focus of the surgery should be on. So I think taking those extra minutes to kind of say, hey, look, I'm noticing this, right? Because the other part that's so hard to teach people about ergonomics is how can you teach them if they're not aware of what they're doing? Right? You say, oh, you're sit up straight. The person I'm working with thinks they are sitting up straight, And you're like, no, you're really not. Like you're sort of hunched. And perhaps for them, because of how many years they've been at these postures, that's the norm. So it's sort
Mm-hmm.
of sort of reeling back what's uncomfortable to say, no, this is actually the norm is a huge turning point. So I think taking the extra moment to make sure the resident or the fellow, whoever you're training, or even your colleagues is comfortable. And then another thing I really think is super valuable is if you don't know how you look like, ask somebody to take a picture of you without the patient
Exactly.
in there, just you and your back and however you're doing. We're recording a few of your cases just to figure out, what do you typically do? Like when it's a stressful situation, do you just sort of hunch up both of your shoulders? Maybe that's why you're going home with neck tension. But without knowing what you actually do, it's really, really hard to correct the problem. And then having those advocates, right? So if you are mindful of ergonomics, you can remind all of your staff and getting them involved to call it out too. I think that really helps to include everybody, because I think proper ergonomics is important for all, not just the surgeons. And so I think this is something that as we talk about it more, it'll become more of the norm culture. And that way, I think that will really effectively have some changes.
Yeah. No, you've highlighted so many important points. And so I'm going to try, like, take a little pause and just try to summarize both in general terms as well as specific terms for our audience. The first thing you highlighted was the importance of, setup and taking that little bit of time ahead of time to do that. In the Society of Surgical Ergonomics, we talk about this as being the ergonomics timeout. So just like you do a pre-incision timeout, this is right after that, but before you make the incision, you do a little ergonomics timeout. And there are studies happening through the society to try and figure out sort of what are the elements of this short, less than 1 minute timeout. But it can be general and it can be specific. So for your specific case, for example, as you said, just taking a few moments to make sure you're at the right height. The microscope is such that you're not, in a really awkward neck posture and that things are within reach, right? Just taking that time to check in. And then you highlighted a second piece, which is awareness. And I don't know if you find this when you're working with residents or trainees at various levels. I think data also supports that the more junior trainees, because they're so focused on the tasks at hand, their muscle tension is high and their postures are not going to be ideal, right? And as they get more comfortable with the tasks at hand, then their postural awareness increases or they start to pay mind to that. Is that correct?
Yes, definitely.
Yeah. So, these are the things that you're right. As we our ergonomics training, probably yours was similar to mine, a lot of it was stand up straight. And hence, the importance of teaching that. And it shouldn't be an afterthought, right? This should be
Mhm.
part of the process that we use. One of the other strategies we talk about, general strategies are regarding breaks. I guess the typical ophthalmology procedure probably doesn't go on for hours, but maybe sometimes they do. How do breaks fit into kind of the ergonomics of sitting at the microscope, for example?
Yeah, most ophthalmology cases with respect to phacoemulsification, which is cataract surgery,
Yeah,
tends to be pretty short, so
short.
about
Yeah.
15 to 20 minutes. However, retina cases, orbital trauma cases with oculoplastics can go on for extended hours. And so I do think it's super important to be mindful that it actually takes a lot more core strength and a lot more pressure on the discs in your back when you're sitting than you're standing. So if we're having back pain, it's actually better if we were standing operating versus sitting operating. So I
Is
think
that
people,
so? Okay.
yeah, it's about 75% more pressure to
Mm,
your discs of your spinal region versus if you were standing. So I think one of the first things is realizing that if you are involved in those longer cases, you definitely have to take more breaks. And then in addition, I also have to be aware of what am I doing in between my cases? Am I jumping right onto my phone where my neck is bent more than 30 degrees flexion? And I'm doing all that and trying to finish off notes and having poor postures in between, because those are really restorative breaks, even though my cases are short, right? And then the cumulative load, because a lot of ophthalmologists may do
mm.
20 cases in a day. So the repetition of those, despite not long in each duration, may also contribute to concurrent stressors.
Yeah, no, absolutely. It's not just about the duration, as you said, it's that repetitive strain injury. Now, you mentioned, loading of the spine, and among general surgeons, the highest rates of injury are in three places, right? It's the cervical spine, the lumbar spine, and often degenerative changes in the shoulder, rotator cuff, etc. How's the pattern different, or is it different for ophthalmologists?
I think the pattern is very similar. I
I
think
see.
even if we were to look at just overall population health, those are
Mhm.
probably the three main areas as we age that
Yeah.
we see issues. So I don't think there's anything super unique about ophthalmologists that would change that. But to your point, I think the biggest issue is, especially for the cervical neck, is as we're learning about the neck, the whole point of our necks was to just hold up our head, which
Mhm.
may be about 7 to 10 pounds at most, right? So when we're putting on more things like loops and everything else, and then we're bending our necks in these super awkward angles, that was never meant for what your neck was supposed to do. If you were supposed to look, you're supposed to actually turn your head, move your whole eyes, like not bend your neck at will. And so I think those are some of the things that we're seeing that we really need to be mindful of.
Yeah, I often say in my talks that, I show this picture, it's from a paper on text neck, and you can see like 15 degrees forward flexion doubles the weight of the head at the top of the spine, and which brings us to what you just said. No wonder we hurt, after doing our work. So before I sort of ask about things that ophthalmologists do in the office and how to set yourself up for success there, I do want to ask a specific, because this is an area that I don't do. I don't work under the microscope, but many of our colleagues who might be listening to this, not just ophthalmologists, but say neurosurgeons and others plastic surgeons who work under the microscope, do you have Dr. Zhang's tips and tricks for positioning yourself at the microscope? For example, what do you do with your arms? Do you need support? Is there a way that you can kind of try to set yourself up well at a microscope?
Yeah, I think for all of us that use microscopes, there are slightly different microscopes, but I think the natural concept is really being aware of what your neck is doing. So I think oftentimes there tends to be that sort of what I call turtleneck, where you're sort of sticking out your neck and then just pushing back your shoulders. And that's really not comfortable, number one. And number two, that's probably not very good for your neck. So most microscopes do offer a setting where you might be able to have a slight tilt of the
Mhm.
oculars towards you. And I'm not talking about like 30 degrees or anything like that, but something just even 5 to 10 degrees offsets, just so that it's a little bit closer. So you're not having to tilt your neck forward to reach the oculars. Some of the manufacturers do make ocular extenders, which is another option to kind of not allow for your neck to extend, but for the oculars to come towards you. For those that sit at the microscope and operate, the height of the chairs are super important to go high enough for those that are shorter and low enough for those that are really tall with legs that may not fit underneath the table. The other parts are the importance of lumbar support. So
Mm,
while I mentioned that, when you're sitting, there's a 75% increase on your load, right? You can
mm.
actually reduce that load by having the proper lumbar support. So it's not saying, okay, once you're sitting down, it's over, your discs are just going to have to suffer. But more so, if we actually had the proper lumbar support for those regions, we can alleviate some of that tension and some of that load. So I think having that surgical chair or stool that offers that is very important.
Yeah, you just brought up an excellent point, and I just remember the couple of weekends ago, we were coaching, our business partner and I, we were coaching surgeons, and we were looking at their setup of the robot, at the robot. And this is a huge issue, like finding the right chair, right? You're sitting at a robot, as you said, and you get like these OR stools that move around, and you're highlighting the same issue while sitting at a microscope, right? You've got an expensive piece of equipment. You're working in a high stress situation, having a suitable chair that fits a wide variety of bodies, that is lockable, that has lumbar support adjustable, right? Because it's going to need to be adjusted depending on the size of the person or the anthropometrics of the person sitting in it. All those things make a huge difference, and I'm often appalled. Like we use these multi-million dollar instrumentation with like these chairs that are floating around, or I see people put a blanket behind the chair to keep it from moving. Definitely more work needs to be done to design better chairs for us to look at, to work at these consoles and microscope. Let's shift gears a little bit to what tips do you give people in clinic? We know that we spend 50% at least of our working time, whether that's at actually physically at work or at home doing charting in the EMR, right? And as you said, that is an additional strain outside the strain we get at the OR. Almost all of us have computer strain, and then you have in your clinics the added strain of working at a slit lamp. So any suggestions for those?
Sure. I'll tackle it first from the generic standpoint where
Sure.
everybody is now confined to a workstation, regardless of
Yeah.
whether you're a surgeon or you're a family practice or primary care doctor. Everybody these days are sort of confined to some medical record that requires computer login. So one of the first tips is just making sure that the monitors are at achievable height so that you're not having to strain your neck either
Mhm.
looking up or looking down, and that it's at the appropriate height. And I think oftentimes we forget what that appropriate height is. And
Mhm.
that appropriate height is actually a slight gaze down position. So it's not supposed to be straight onward, but about a 20 degrees gaze down position so that you're maintaining that neck neutrality. I think the other part that not many people talk about is the room layout, right? So if you have a specific piece of furniture in which the laptop, or maybe not the laptop, the computer is sitting on, you're sort of confined to what you can do.
Mhm.
And oftentimes there's a lot of turning of our trunk regions if we're sitting down as we're
Mhm.
examining patients or talking to them, where you purposely have to pivot in order to see the patient because of how your room is designed. And that furniture and that desk is bound to the wall. So really, you can't really be super imaginative to like change it around. So I think many of us in light of trying to make sure that the patient has full understanding, do a
Mhm.
lot of that turning back and forth and awkwardly turning our bodies to accommodate. And I just worry about when we're doing that, how much additional stressors that we're taking in. So I think having a little bit more understanding of the factors of room layout and what would be an efficient way so that you're able to see the patient, you're able to see the chart and maybe share some information with the chart without having to pivot so much from all angles would be super important. So I think that is something that everyone who is having to be confined to any kind of workplace station can benefit from. And to your point, perhaps we should be designing better chairs for those work environments, right? I think that's the least of what people think about. They'll grab a stool with no wheels, even just drag it in and be like, okay, go ahead, type away at the computer. It's not even adjustable height.
Yeah, I just had
Um,
this vision of myself in clinic, and I do exactly that. I kind of sit on the stool and I go, wee, right into the computer space, and then wee right towards the patient. So, this is a struggle. And as you said, we're kind of confined by the design. And this kind of speaks to what one of my general surgery friends, colleagues, trauma surgeon, Dr. Hina Santry, she actually works in design and she talks about this a lot, architectural design. So when these spaces are being conceived, right, it's really important to take the input of the people that are actually going to be working in that space. Please don't put the monitors and lock them to the wall when they're going to be completely opposite facing to where that you're putting the where you're putting the sort of space for the patient to sit, right? Or the examining table. As you said, we can take the initiative to set it up as much as we can for ourselves, turn the screen as much as it will go, get it to the proper height for you, or elevate your stool if you have to take a look at it, elevate your chair. What about the slit lamp? Again, any tips for that?
Yeah, so for the slit lamp, very similarly, it's an upright microscope. So I always tell my residents or other colleagues that if you're experiencing where you're kind of leaning in more so to sort of pull the slit lamp towards you. Oftentimes, you try to really accommodate the patient and kind of push it back towards them. And in terms of the patient chairs in which you're sitting, the patient is sitting in, it really promotes that culture of leaning back, which
Mm,
in thinking, we actually want them to be projected forward. So actually, I want the patient to be at the edge of the seat so that they're able to kind of come forward and rest their chin on the chin rest and forehead touching that strap to come forward enough so that I can do my exam. But the patient chair is just like any other chair that I think is shared by ENT as well as dentistry. So it's not
mhm.
very specific. And people tend to sit back in their chairs as if they're at home lounging. So it's a little bit of difference when you're like, no, 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 I actually want you to move forward just a little bit. But I think realizing that and having that open communication, because if you think about it, having a patient move forward a couple of inches for that one exam is probably okay. Obviously, if your patient has some mobility issues and cannot, then of course go towards them. But if you're seeing 20, 40, 60, 100 patients throughout the day, and every single time you're catering because you're having to lean in more, that is a long time versus maybe the minute or two that the patient might be slightly uncomfortable for the exam. I think realizing that and asking the patient if they wouldn't mind moving forward just a little bit is a very important first step. I think some other opportunities are that certainly talking with microscope reps and saying, if there could even just be a slight cutout so that I could physically get closer, that would
Mhm.
make it a lot easier. And some of the microscope companies have actually listened and are adapting that. So I think it brings up the importance of whenever we as consumers, right, as consumers of devices, we should have some input before it's designed, before it becomes a problem, so that we can say, as a person who uses this every single day, I can already see where some of the problems may be. And perhaps we should mitigate that before just rolling it out and then having to go backwards to try to fix it. And there's not really much incentive to fix it once the product is out because it takes a lot to remake a product, things like that.
Absolutely. If we're going to say something, we often say it to the people that are, we're seeing in our ORs, and those individuals from industry are actually sales reps, right?
Mm-hmm.
What we want
Mm-hmm.
is our message to get to the design team,
Mm-hmm.
the human factors team, and it would be great. And I think the Society of Surgical Ergonomics, which you're a member of, I'm a part of, say the Industry Collaborations Committee, that's one of its goals. And we've started to have those conversations about sort of incorporating and getting feedback early on in the design process from the end user perspective, right? That's, as you said, if that could be done before, it's much, much easier. And, to your point, even like if you look at the recent sort of upgrades in the robotic consoles that we see, there is a bit of a curvature, just like when you get your, desks ordered, they have that little bit of curvature so you can move forward. And there have been adjustments, to the eyepiece of the robotic
Mm-hmm.
console. Just like you said, the microscope manufacturers working on that as well. I guess from my perspective, the principles are the same for good ergonomics, whether you're working in ophthalmology, orthopedics, or general surgery or gynecology, right? All the key things, the positioning, postural awareness, and then resetting the posture by taking breaks and perhaps doing stretches, and then paying attention to all these things outside of the OR as well. I want to let our listeners know that I actually first became acquainted with Dr. Zhang at last year's Society of Surgical Ergonomics annual symposium. And she was giving a talk on the topic of the effects of presbyopia on surgeon and procedural ergonomics. Now, as someone who in the last few years has developed presbyopia, I'm going to say surgeon of a certain age or proceduralist of a certain age, or maybe a scrub tech of a certain age, okay? So all of a sudden, you need either bifocals, or you need, contacts, multifocal contacts, or multifocal lenses like progressives. And all of a sudden, it becomes an issue to look at screens if you're doing laparoscopy or computers. So, can you tell our listeners a little bit about, well, one, how did you get interested in this particular topic of ergonomics, presbyopia and its effect? And how does the development of presbyopia or its treatment actually affect the ergonomics of people working in the operating room?
As an ophthalmologist, we clearly see a large percentage of the population that develop presbyopia. And so in that sense, I was well aware of what presbyopia is. I really didn't have a specific interest in looking at the ergonomic implications until my colleagues in other specialties, as well as my colleagues, fellow ophthalmologists, have mentioned that, ever since I got that progressive pair of glasses, I've been noticing a lot more neck pain. And it's sort of like, oh, why would that be true? And if you think about the design, so let's focus first on the glasses portion. So there are many different opportunities or changes that you can adapt to your glasses to allow for that near focus. For those that may not understand the definition of presbyopia, it's sort of that inability to accommodate or an inability to see up close without some assistance, either from glasses or contacts or any other methods. And so when that starts occurring, we start having to, for those that never been wearing glasses, all of a sudden have to start wearing glasses. It's a foreign concept. And then what happens is when we're realizing that the amount of focus or the amount of lens power that we need varies for all the distances. So it's not just one power. It's not just like putting it on and then I can see near, far, and distance. No. Those are different focal points and those are different refractive errors. And so your glasses has to kind of mimic what your eyes would have naturally done when we were decades younger. So it's sort of like, of course, it's not going to be as good as what we were originally born with. So I think some of that frustration is realizing that there's going to be compromises and there's going to be limitations to what the glasses can do. And so oftentimes when people get their first pair of bifocals, trifocals, or progressives, they're not really understanding that, there are set segments or there are set views of what your focus is. And if you are not communicating that very well with the eye care provider, who may be an optometrist or an ophthalmologist, who may not know what kind of surgery you do or what work environments you're in, it's really hard to figure out for you what would be the appropriate lens. We might just stick in what we give to as the norm for everyone and then just go be about it. And for somebody who may not work in the OR or have those very specific constraints, it probably works, I would say, 80% of the time. However, for those that have very specific tasks and you're noticing you're having to bob your head a lot just to find the right zone to look out of, it can certainly add to the ergonomic strain because it sort of constricts you in terms of how you can look at something, because otherwise it's not going to be clear. So which one would you sacrifice? Would you sacrifice the ability to see, or would you sacrifice your neck and shoulders a little bit, or your neck, just so that you're able to get into focus? And I think many of us would choose the latter of the two. And then we say, oh, why am I having more problems when I'm supposed to be the expert on ergonomics, and yet I'm having these issues, right? So I think realizing that and realizing, everyone gets presbyopic. And so all the surgeons at some point will get presbyopic, made me realize, oh, maybe there is something we can explore. Maybe we can develop a tool that will set up that communication with your ophthalmologist, optometrist to better guide to your specific set of glasses. And the other point is to realize that maybe you might need a couple different pairs. And it's not just one pair that's going to fix everything, especially in the work environment of the OR.
By the way, I wish I had known this when I first required progressives. My first pair wasn't so bad, but the second one, where the prescription was higher, myopia was worse and presbyopia was worse, that's when I started noticing this head bobbing, as you said. And for me, In the OR wasn't so bad because my ergonomics were better as I developed presbyopia because I actually had to hold my head back a little bit rather than kind of flexed forward. So initially it was actually okay. But then later on, as I said, as I got the corrective lenses, the head bobbing started. And it was really hard, especially when you are going from the operating room to the clinic and back. And I really struggled with computers. And especially in clinics when they are, as we just discussed, they're set at a fixed point. At home, I can move my screen back and forth and match the focal length for my progressives where my mid distance is. And for work, I think I have an eye appointment coming up, and I'm going to do what you have suggested, which is maybe describe my work, my day-to-day work. Yes, I'm in the OR, and yes, I need over and above 20/20 correction because I'm trying to look for nerves and parathyroids. But when I'm not there, I really struggle with the work computer, and I probably need a second pair of glasses for the mid-range. Okay. So I think I'm going to spell that out, and maybe do you think it would be helpful if I actually had a tape measure and roughly told them what distance I have to work at in clinic?
Yeah, they actually published in the Annals of Surgery about
Ah,
a specific toolkit measuring the respective distances that you were covering. So we had one for like reading, the OR, and the workstation. And to your point, if you could actually do those measurements, it would be super helpful because telling someone mid distance, we're just guessing what that mid distance could be. But if you actually had measurements, those can translate over. As you know, for focal points, it is a calculation, it's a mathematical calculation. So the add power of certain distances can be figured out. So I think having that knowledge or having that information to share with the optician or ophthalmologist, as well as optometrist, as well as
optometrist.
the optician who actually puts those where the focal points are,
Yeah.
is super important. Just so that
Okay.
they're aware, because if you tell them, I'm a parathyroid surgeon, they're like, great, okay. They have no idea what
Yeah.
type of working distance, right? And you're like, I need that mid distance to see the nerve. They're like, okay, they don't know how high you are from the patient, what that means, right? To them, they're like, okay, we'll give you the standard plus 250 plus two, given it's a generic one just based on age. We have some just for just as a rough estimate. But
You know,
if you
I,
had those, it would be much more specific.
I think I am going to do that. So I'll say I'm just sitting here kind of with a smile on my face for our listeners because I just realized that that's exactly what my prescription is plus two with something, something, because I say this is what I do. So for everyone, the article that Dr. Zhang just referenced, I'm actually going to put it in the show notes, and it has some figures with this toolkit that Dr. Zhang and her team has developed to kind of help us actually help anyone, but particularly, since we're talking about surgeons and proceduralists, really take those specific measurements the next time we go to our eye exams so our eye care provider can understand exactly what distances we're talking about. And, as you said, one person's mid distance is not the same as another person's mid distance. Gosh, I wish I had had this conversation with you before I got my last set of glasses. It would have saved me a lot of, I call that sniffing posture while I'm looking at the computer. This is fantastic, actually, all great pearls of information. And I hope that our listeners are taking note. By the way, we'll also list your contact information on LinkedIn. If people are interested in reaching out to you directly, they would be able to do that. I always find with these podcasts that the time just marches on rapidly, and I think we're coming towards the end of our time. But I kind of do want to ask before we officially wrap up if you have any other tips for our fellow colleagues, aside from the ones that we've already talked about, when it comes to kind of dealing with these issues relating to presbyopia.
Yeah, I think one of the first steps is to speak up. And so if you get that first pair of progressives or bifocals or your trifocals and you're doing a lot of head bobbing and you gave it a couple of days, tell someone, return it back. Say, hey, I'm noticing I'm doing a lot of this.
Mm-hmm.
And, perhaps the segment heights, which is the different heights for the different regions needs to be adjusted. What are the opticians, oftentimes those are the people who make the glasses, sometimes are really knowledgeable about the newer technologies that are out there that may give you like more mid-distance versus near distance, depending on what your needs are. So having that really frank conversation instead of just saying, okay, I just need to get used to it, so I'm just gonna suffer, and then the next year when I go in, I'm gonna say something. Realizing that this is a problem because you're struggling with it, and not sort of just keep quiet about it. So that I think that general education, because if you're talking about it, I'm sure your scrub nurse, your circulator, all the other people in the OR are all going to chime in and say, I have that problem too. And I think just knowing that it's not uncommon and to address it is super important.
Oh, this is fantastic. And I can't help myself, Amy, I'm going to say. So if you don't see something, or you have people take videos of yourself and pictures and it looks like you are in that sniffing position, please say something. Very good advice for all of us. Once again, Amy, thank you so much for taking the time out of your really busy schedule and sharing your expertise with us here in the Surgical Ergonomics podcast, and for being so deeply invested in both a physician as well as the ergonomics for all of us working in the OR and procedural suites.
Well, thank you so much, Gita, for inviting me on. This is an excellent opportunity. I'm so glad that you're giving us a voice to share our experiences. And thank you so much for all the great work that you're doing.
Thank you. Likewise. Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.